Yes, yes, yes.
Sure. Shall I start, ma'am?
Yes, 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 Dr. Suman.
So good evening, doctors, and all the participants for today's session, the icons in conversation with Dr. Ritu. And the topic of the program, today's program, is vulvo-vaginal atrophy, a neglected tragedy. And our guest speaker is Dr. Sheikh Jinnat Nasreen, madam, and the moderator is Dr. Ritu Santwani, madam. So it's my honor to introduce Dr. Ritu Santwani, madam, although madam doesn't need any kind of introduction. Just a few words, it's my formal responsibility. Madam is the director and IVF specialist, Shamwell Women Clinic, Pune, and she has more than 20 years of experience in obstetrics and gynecology service. Apart from clinical experience, madam has also attached with many renowned societies, national and international, and in terms of academic activities, she has many engagement. So with this short introduction, let me introduce our honorable speaker, Madam Professor Sheikh Jinnat Nasreen, madam. Madam is the professor and head of obstetrics and gynecology, ZH Sigdar Women's Medical College and Hospital. She is the chairperson, Scientific Committee, OGSB, Obstetric Society of Bangladesh, Secretary General of BMS, Bangladesh Menopause Society, member Secretary of CPD Committee of BCPS, Bangladesh College of Physicians and Surgeons, Secretary General RCOG Representative Committee of Bangladesh, Organizing Secretary of BPS, CAMS representative of IMS, International Menopause Society. Madam is the co-chair, Maternal and Fetal Committee, SAFOG, chairperson website of SAFOM, council member of SASSM, and member of faculty of SRH of Royal College, UK. And apart from that, madam is the editor-in-chief, journal of JH Sigdar Medical College and Hospital, and member of IMS. And she is the course director and facilitator of ALS program of Bangladesh, having national and international publications. So with the short introduction, I request Dr. Ritu Santwani, madam, to take over the session for further proceedings. So thank you very much, madam.
Yeah, thank you, Dr. Suman. So very warm welcome to all our dear friends who have joined all across the globe. And I'm really grateful to Jinnat Nasreen, madam. Madam always accept my invitation. I know madam schedule is very, very busy. And I have done 4 or 5 programs already with the madam. All are very, very highly appreciated by all. Madam's lecture is like a pearl of wisdom. Every time we get some new information on the related topics. So friends, as all of you know, there is a famous quote that knowledge is the power. So how many of you agree with me on this? I'm able to see at present 17, 18 doctors are here, more are joining. So how many of you agree with me on this, that knowledge sharing is the power? Please write in the chat box. No one is writing. Dr. Suman, what's your opinion? Are you agree on this?
Yes, ma'am.
No, I am not agree on this. Not knowledge is the power, but knowledge sharing is the power in this digital era.
That's true.
Yes, because we all are now in this digital era. As much as we share the knowledge always increases by the sharing. So friends, as you all are aware, our today's topic is a very interesting topic regarding the vulvo-vaginal atrophy, a neglected tragedy. For this, who will be the best speaker other than the Jinnat Nasreen madam? So madam is very eminent speaker from the Bangladesh, and I think those who have attended my earlier academic marathons, madam was in my 3 of the academic marathons. In all the academic marathons, I got numerous inbox messages that madam's talk was excellent. So ma'am, a very, very warm welcome once again, and over to you. Yeah.
Thank you very much, Ritu Santani, for your kind words. Actually, I am really honored to be the part of your marathon. And really, every time, whenever I am watching your program, it is wonderful, with a full of academic fest. Thank you so much for inviting me. Thank you. Okay, so should I go for the scarce training?
Yes, ma'am. Yes, ma'am. Ma'am, before you start, let me tell you that so many doctors have joined from the Australia, from the Arab countries, from Pakistan also, and from Spain also. Yeah. See, ma'am, your popularity. Huh.
Thank you. I'm so honored, and I'm really grateful to all of you. Get started. Just a minute, please. One minute, please. Huh?
Yes, yes, no problem.
Sure. It is in my desktop, but I don't know why it's not coming. Channel. Atrophy.
Meanwhile, madam is starting the presentation. So friends, if you are having any queries, please do write in the chat box. After once the madam's lecture is over, we will happy to take all the questions.
Can you see my screen?
Yes, yes,
Ritu?
ma'am. Yes, ma'am. Ma'am,
Should I go for the full screen?
that will be much better, ma'am. Yeah,
Okay. Okay. Thank you very much. Is it okay for you all?
Yes, yes.
Okay. Okay. Let me start then. Huh?
Yes, ma'am.
So my greetings from Bangladesh to Ritu Santani, her team, and all the viewers today. My topic of presentation today is the vulvo-vaginal atrophy, a neglected strategy, or the strategy. Well, the vaginal health is an essential component of active and healthy aging in women at menopause and beyond. Vulvo-vaginal atrophy may be the problem at any age. It affects more than 70% of menopause women. Vulvo-vaginal atrophy are also, it is known as urogenital atrophy, is replaced by a newer nomenclature that is called genitourinary syndrome of menopause. It was introduced 2014 because the vulvovaginal atrophy indicates only the atrophy of the vagina and vulva. But the thing is not like that. In fact, the atrophy touches the vagina, vulva, urethra, bladder, and the sexuality. That is why the new nomenclature is the genitourinary syndrome of menopause. And also, it removes the stigma for the women to having the vaginal dryness. Due to the loss of estrogen, the vulvovaginal tissue becomes atrophied and the vagina becomes more alkaline and vaginal secretion can decrease a lot. Women suffer silently, but they're ashamed to speak out. And they drowned into the inferiority complex and insecurity. Even they're reluctant to describe their healthcare providers without knowing that there is a restorative treatment. And that is the tragedy. The irony is that the women are coming to us. Yes, the few women, they are complaining, they are coming, especially in Southern Asia, but that is the tip of iceberg. And we, the providers, need to melt that iceberg to make them speak out what is the tragedy.
Madam, sorry to interrupt you. Slides are not visible now.
Now?
No, not visible, ma'am. Only the desktop is visible.
Oh.
We are able to see the vulvovaginal atrophy is here, but not the full slides.
Is it moving now?
No, ma'am.
What happened to that? Okay. Let me stop to share.
Okay, you stop sharing and again share.
Oh my God.
No problem, ma'am. Yes, ma'am. Yes, now clearly visible.
So that is the tragedy. I mean, women, they are oblivious. They're not coming to us. Even they don't know even that there are some restorative treatment and they can be improved by the treatment. And of course, I already mentioned, some women are coming in our part, and that is only the tip of iceberg. So being a healthcare providers, it is our duty to make them speak about their problems. So what is the effects of the vulvovaginal atrophy? Well, it can significantly impair the health, sexual function, and at the end, the quality of life. complaints of vaginal pain, burning, sore, dyspareunia, and urinary problems, and sexual dysfunction. And these all together lead to severe emotional distress and adversely affects the conjugal lives and their disharmony in their conjugal life too. So the repercussion of all these negative symptoms often necessitates initiate treatment. It has to start the treatment initially, urgently. Otherwise, this condition becomes a chronic, progressive, and very devastating. But irony is that vulvo-vaginal atrophy or genital syndrome of menopause remains underdiagnosed despite its huge or high prevalence because the women are reluctant to speak. And Revive survey, they commented that the onset of VVA symptoms, the majority of women starts their symptoms in the early postmenopause, not that they have to pass so many years to be menopause. It may start even the earliest part of the postmenopause. Well, there are a lot of causes of the vaginal dryness. Yes, we know that cigarette smoking, premature oophorectomy, Sjogren's syndrome, radiotherapy, chemotherapy, any infection by bacteria, yeast, parasite, and certain drugs like antihistamine, anticholinergic drug, antipsychotic drug, tamoxifen, danazol, GERD analog, and agonists, aromatase inhibitors. They all can produce vaginal dryness, but the low estrogen, that is during lactation and the menopause, is mostly concerned and talking today. Estrogen receptors are abundantly present in the vagina, vestibule, urethra, trigon of the bladder. So withdrawal of this estrogen, they totally changes the anatomical condition of the environment. And the estrogen also decreases during menopause. And the structural changes, what happens? Number one, there will be collagen hyalinization, elastin degradation, epithelial thickness will decrease. Then the blood vessels supply was decreased, introital connective tissue is decreased. And there's a regression of the labia, retraction of the introitus, loss of elasticity of the hymen, and the prominence of the and vulnerable urethral meatus. There's a reduced vaginal blood flow, diminished lubrication, decreased flexibility and elasticity, and there's the increased vaginal pH, which is totally hostile. And if you look at the vagina, healthy vagina, we can see that vaginal epithelium is very thick and lots of blood vessels are usually present before the menopause. But soon after menopause, it is the vaginal epithelium that is diminished in thickness. Also, the connective tissue sparse and blood supply is very less. Thereby, the vagina already becomes narrower, thin, paler, and non-elastic. And the mucosa, I already mentioned, the paravasal cells becomes only the cells. All the superficial cells, they disappear. And the superficial cells are the key asset of the vaginal health, but that is deficient because of estrogen deficiency. Similarly, what happens in the urethra and bladder, you can see that urethra was surrounded by thick mucosa, thick subcutaneous tissue, thick lamina propria. But during menopause and beyond menopause, because of the estrogen deficiency, the urethral meatus becomes enlarged, whereas the lamina propria, subcutaneous tissue, the muscle tissue, all are thinned and thinned out. Similarly, there is bladder mucosa is also thinned out during the menopause and after menopause because of estrogen withdrawal. What about the sexuality? I mean, sexual life is severely disturbed because of the estrogen deficiency, dry vagina, and the aging process. And it has been seen from all the publications, these are the publications, that there's a 7-fold sexual pain disorder, 4-fold sexual arousal disorder. So estrogen deficiency leading depression and sexual dysfunction. Gradual drop in androgens also with the age precipitating and predisposing the decreased arousal, decreased desire, and the sexual pain disorders. So as a whole, we are seeing that the psychosexual life is also disturbed for women. And the Pan-Asian Revive survey, it is done in 2017. Yu Chuang and his group, they have said that the VVA greatly impacts sexual enjoyment, about 65%, and intimacy, about 61%, and it causes extreme sufferings of women. And the single entity of the dyspareunia affects all the domain of sexual dysfunction. So a simple dyspareunia ultimately leads severe sexual disorder. The CLOSER survey by Rosalina Nappi, she has investigated what is the impact of VVA on postmenopausal women and the male partners. She found that the intimacy avoidances was attributed to painful sex by women 55% and men by 61%. I mean, men are very concerned with women. They refrain from sex because they are also scared that women might get pain. Well, the severity of the VVA varies because Moral et al., in his publications, he found that, well, 93% women might suffer from VVA, but good thing is that among them, 68% suffer from severe cases. In Southern Asia, in our country, neighboring countries, usually 20% of women, they suffer from severe atrophy. Diagnosis, it is all you know that we have to take a very good history, we have to do clinical examination, and we of course need to do investigation. But for a vulvo-vaginal atrophy, typically providers can diagnose vulvo-vaginal atrophy by physical exam alone. But still, we have to ask the history. I mean, what type of atrophy she is feeling? What is the onset? What is the duration? How much she is feeling? What is her condition? Whether she's suffering from repeated UTI, urethral burning, dysuria, then nocturia. What about the sexuality? What about the vaginal dryness? What about the partner relationship? All the things we actually need to evaluate from the history. And assessment is very important because we have to also know that whether she's using any irritating or any irritants in the vagina, douches, Savlon, bath gels, soaps, alkaline soaps, lubricants, if their lining pads are very hot, and whether she's suffering from any chronic illness. I have already mentioned the causes like autoimmune disease, Sjogren's syndrome. So, from the history, we have to find out. We should not be very much biased that menopause is the only cause of atrophy. We need to find out whether there are differential diagnoses are not there. Yes, physical findings is very obvious. Alteration of the vaginal mucosa makes it pale and fragile, and might be some discharge. Of course, we can find that this picture is very obvious. In the healthy premenopause women, the labia minora majora are very thick and quite full. But after menopause, it becomes thin, and the clitoris becomes very prominent, and vestibule urethra dry, thin, and also the diagnosis is made by some vaginal physical examination as well as some investigation. Colposcopy. If you do the colposcopy, you can find out that the epithelium is becoming very thin, very pale, and there are a lot of petechial hemorrhage that can be also detected. But regarding the investigation, well, it is not mandatory to diagnose the vulvovaginal atrophy. We can take the history, we can just have a look, we can examine, we can do the PV, and even if you want to do the pH of the vagina can be examined, and it will be, elevated, and it will be above 5. And saline wet preparation reveals the relative acellularity and increase in the paravasal cells. But in case of premenopause, the women are having more superficial cells, what I have showed already in the picture. Maturation index, again, is not mandatory, but sometimes, when women are suffering severe atrophy, we are giving some treatment, and to follow up the treatment, we can go for the maturation index. I already mentioned that women are oblivious and reluctant to discuss this issue. So, International Society, Menopausal Society, they recommended for all the healthcare providers to become empathetic. They should be proactive in history taking. And even though women are coming for other causes, we have to make a report with them, and we have to reveal whether they're suffering from silent vulvovaginal atrophy. So, if we go for the algorithm, we can say that hypoestrogenism, it causes thinning of the vaginal epithelium. It becomes very thin. There's exfoliation of the vaginal epithelium, superficial cells. Glycogen produced by exfoliated cells are decreased. So nutrition for the lactobacilli, it is decreased. So number of lactobacilli also decreased. And the lactobacilli are who are producing lactic acid. As they are decreased in number, so there's a less production of lactic acid and the pH thereby increase. And increased pH invites the growth of bacteria. And also there is a urinary tract infection. And repeated urinary tract infection occurs because of the dryness of the urethra as well as the trigon. Similarly, it is dyspareunia because of the thinning of the vaginal wall. So, if you look at the treatment, what is the approaches of treatment? Well, definitely choice of treatment depends on the severity of the symptoms, the effectiveness of the safety of the treatments, and the patient's preference. But what should be our goal? Well, we always need to improve the symptoms, relieve the symptoms, and we will try to apply such things which can restore the vaginal anatomy to premenopause era. So we have in our hand general treatment, that is general for all women, non-hormonal therapy, hormonal therapy, and alternative therapy. So regarding general treatment, I don't like to discuss more. Actually, we are always we become very biased to treat only the local areas, but we need to be holistic. We should provide a holistic approach of treatment. So only looking at vagina and not looking other parts of the body will be not enough. So we have to look at the lifestyle modification, whether she's maintaining her body BMI, and healthy diet, whether she's having healthy diet. And of course, we would suggest them to maintain the optimum body weight. And EVAS data indicated that treatments should ideally be initiated early, before the condition becomes very severe. I mean, whenever the menopause ladies are coming for any reason, we have to look at their health and their mental and their sexual life, as well as the inquiry of the vaginal atrophy. Yes, exercise. I mean, the question arises, why exercise? How exercise can help the vaginal dryness? It has been seen that women, if they do the exercise, there will be increased blood flow into the vagina, into the perineum. And the muscle, I mean, perineum will relax and squeeze the muscle. That helps to maintain the vaginal health, because we know that vaginal muscle also gets atrophy. So exercise really helps them. And also women should avoid smoking, drinking too much alcohol. Why smoking should be avoided? It is a general health condition, but for atrophy, we have seen that smoking is linked to increased estrogen metabolism. Already she's deficient in estrogen, so we should not do much harm with smoking. And of course, other beneficial effect has to be discussed with them for quitting smoking. Awareness. I mean, well, many women, they don't know even that they are suffering from vaginal atrophy, and it need to be addressed, it need to be diagnosed, it need to be treated. So if we really research on, I mean, newer treatment for the vaginal dryness, but if the woman doesn't come to us, is the women sitting at home, what will be the benefit? So it is our prime duty to have advocacy program to make them aware that there are treatment, they should come forward. These are the symptoms of vaginal atrophy. If they don't come, it will be progressive, it will be chronic to such a point, then it will be very difficult to revert back them. So what are other treatment approach? Non-hormonal treatments are the vaginal lubricants and moisturizer. I mean, lubricants is a very common. It is been found in the over-the-counter. They could be water, silicone, or oil-based product like KY jelly, Vaseline. Because if they use, the women when they're using lubricants, it prevents the friction during sex. That gives actually temporary relief. So definitely they can use the lubricants. But vaginal moisturizer, they consist of such components that adhere to the vagina and along the secretion, they prevent the dryness, while the vaginal lubricants, they can't prevent the dryness. They are used only during the intercourse, and temporarily they can help. But moisturizer, they are long-standing, they adhere to the vaginal wall, they retain water, and they rehydrate the dry tissue. And it's very important to know that women feel pain-free, orgasmic if they're wet. And if they're dry, they can't do that. So moisturizer also can be used if it is necessary. But as a providers, healthcare providers, we need to check the moisturizer and the lubricants before prescribing. We have to look at the composition of those lubricants as well as the moisturizer, where the osmolality should be between 380 and pH should be between 3 to 4.5. And it is very useful when estrogen is contraindicated. And also, when the women are suffering from mild to moderate to vulvo-vaginal atrophy, they can be the first choice. Sexual intercourse is also an important part of therapy because if we advise them to have sex regularly, it maintains the vaginal health by regularly increasing the blood flow to the vagina. There is a liquid lidocaine compressor. It's not in our place, but it has been in some country in America. It is available. They compress on the vestibule before just sexual penetration, and that relieves the pain. And women are happy, and they want to use more and more. 90% women reported they are comfortable with those liquid lidocaine. What about the hormonal treatment? Well, we all know that it is happening because there is estrogen deficiency and there's a menopause. Ovaries are not producing estrogen. So definitely the low dose vaginal estrogen could help. So there is a low dose vaginal estrogen. There's a vaginal DHEA, and local estrogen therapy are effective treatment for severe vaginal atrophy. Local estrogen therapy is highly effective, and I can't see actually all these things. Just a minute. Yeah, now I can see. They can they can change the physiological changes associated with GSM, and they foster the vaginal cell growth. That is a very good thing. The superficial cells are, they regrow, and also they help with maturation and favors the lactobacillus colonization. So that lactobacilli, we know that they produce glycogen and the pH becomes lower. So estrogen, it improves the blood flow, lowers the pH, increase the vaginal epithelial thickness, increase the elasticity, increase lubrication, and enhance sexual function. The treatment should not be considered for short time. That is important. So actually, it has to be used for 6 months, or at least the long-term 2 years we can use. The treatment should be considered, and it needs long-term therapy. So we have a lot of types of modalities of estrogen therapy. The first of all, estrogen local cream is very effective. I already mentioned the mechanism of action, and this is dispensed at VJ form, tablet, in the form of cream, in the form of ring, ester ring, and they all are equally effective. Estradiol local cream can be used by 50 microgram daily for 2 weeks, and then twice in a week, 3 months, 6 months, according to patient's response. Even it can be used 1 year. Cochrane review concluded that vaginal estrogen in different forms was superior to placebo for the treatment of genital syndrome of menopause and the VVA. Because lubricants and moisturizer, they can't grow the vaginal cells. They can't meet the demand of estrogen deficiency. But local estrogen hormone, they can do that. They can revert back the anatomy, at least in reasonable way. And tablets are also available. It is very easy to administer in the vagina. Vaginal ring, the beauty of vaginal ring is that it can be kept in the vagina for 3 to 6 months. And it's also licensed for long-term use, even up to 1 year. So with correct dosing, the correct dosing of the local estrogen, the systemic absorption of vaginal estrogen remains in the postmenopausal range, and that doesn't need or require a progestin for the prevention of endometrial hyperplasia and cancer. So many students usually ask this question, madam, we are using local estrogen for 1 year, 2 years. The data are showing the safety that is up to 3 years. So usually we don't use more than 2 years, but if it needed, we can give a gap, again we can start. So do we need to start progesterone to prevent the endometrial hyperplasia? Well, the answer is like that it doesn't absorb in high amount, only which is absorbed, which remains within the postmenopausal range. So progesterone doesn't need to be added. What about the other hormones? Before I'm going to testosterone, the question is there that whether systemic estrogen therapy eliminates the symptom. Yes, it eliminates the symptom about 60 to 75% of cases, but the randomized controlled trial showed that local therapy does or improves vaginal atrophy in 80 to 90% of cases. And the safety profile of the local estrogen is very high than the systemic estrogen therapy. Existing data provides some support for local testosterone therapy. And there are a lot of studies are showing that local testosterone, they might help a lot because they stimulate the vaginal mucosa, they improve the vaginal dryness, increase the blood supply. But till today, because of lack of long-term safety and efficacy data, testosterone is not recommended for the local use. Testosterone is only used when the women, postmenopausal women, suffer from hyposexual desire disorder. So this is very clear on this point, because many of the with the due honor GPs, they want to use the testosterone. They are coming to us and asking, but definitely until today, there's a recommendation that testosterone can only be used in women who are suffering from hyposexual desire disorder. And also for them, should not be used more than 6 months. Because after 6 months, if they don't get any improvement, then there's no point of using testosterone for longer time. What about the DHEA? This is a very promising local treatment, very commonly known as Passcode, that is insert actually, 6.5 milligram insert that can be introduced during the bedtime. And this penetrates to the vaginal wall very better, and it's increased the vaginal mucosal thickness, elasticity, and also improves the blood supply of the vagina, thereby improve the vaginal dryness, vulvo-vaginal dryness, as well as the urethral and vestibular dryness. Daily application is recommended. DHEA actually, it has to be applied daily locally, because if we give systemic application, the randomized control trial doesn't favor the systemic applications of DHEA. And RH, I already mentioned that RCT haven't shown any benefits of systemic therapy, so it has to be given locally. Because locally, DHEA converts dihydrotestosterone to testosterone, also estradiol to estradiol, that is the active form of estrogen. What about the non-hormonal treatment? Well, ospemifene, a third generation SERM, is very popular, which is used 60 milligram per day. This is the only drug that has been used for the female sexuality as well as vaginal atrophy. And it also improves the vaginal epithelium. The beauty of this drug is that it is an agonist to the epithelium. That means it helps in the regrowth of the vaginal epithelium, but it is antagonist to the endometrium. So it doesn't increase the endometrial thickness, and also it has not increased the breast thickness. So it is a very good option to treat the vulvo-vaginal atrophy when the estrogen is contraindicated. It is well tolerated and it has no cardiovascular risk, but it is related to the thromboembolic. All the SERM are related to the thromboembolism. So you need to be very careful when prescribing the SERM, ospemifene. TSEC, it is a very new drug. I mean, tissue-specific estrogen complex are now being evolved, and it's not available in all the countries. Few countries of the world they are getting this. So this actually the combination of the bezodoxyfen and conjugated estrogen. You can see that there's no progesterone. Laser therapy. Well, laser therapy is very promising. It is simple, faster, painless procedure, and it of course activates the dominant fibroblasts. That is its beauty, and so it increased the degraded collagens tissue, and it also retained the hyaluronic acid. So water is retained in the vagina, blood supply is improved, and thereby it ameliorates the dryness of the vaginal vulvo-vaginal atrophy. There's a lot of controversy with the use of laser, particularly American and Canadian Menopause Society and other societies are not happy because there's no long-term safety data. But just recently, 2019, the long-term safety data came to 2 years data that microablative fractional carbon dioxide laser, non-ablative vaginal ebrium laser, and energy-based devices are increasingly used because this alleviate and it has a very good safety profile. But still, it is not routinely recommended. And who will use that? They have to have very well trained. And regarding some other drugs like gabapentin, selective serotonin reuptake inhibitors, norepinephrine reuptake inhibitors, you all know that they are used in menopausal women for hot flashes, vasomotor symptoms. But unfortunately, the role of these drugs to combat vulvovaginal atrophy is not yet been established. Rather, there's a notion that it reduces the vaginal lubricants. But A.K. Shiha, she has a very beautiful study where they negate the negative activities of these drugs. And finally, the pelvic floor muscle program. This training program is important for the women who are suffering from urinary incontinence, because urinary incontinence is also a very important part that is. So probably if you give the PFMT, it displays positive impact on the activities of the daily living of those women. Other complementary therapies such as oral vitamin D, vaginal vitamin E, probiotics, it's being talked all over the country, all over the world even. The vaginal dilators when very much stenosis, these are coming up. G-shot, it is very interesting that PRP is injected in the posterior wall of the vagina. That stimulates the stem cell on the vaginal floor, and thereby it increases the vaginal rejuvenates the vagina and sexuality. Botox are one kind of filler. It can be used to fill the vaginal mucosa, but actually all these non-hormonal treatments or complementary therapy, we cannot prescribe because the data on their efficacy are still scarce and further studies are required to recommend them. So the vulvovaginal atrophy actually needs to be an menopause is inevitable for each and every woman. It is a natural event. But VVA needs not to be an inevitable consequence. Early diagnosis and its early timed intervention can prevent the progression and adverse effect. VVA is common, but is underdiagnosed and undertreated. Women are silent, so healthcare providers need to come forward and break the silence and solve their problem by offering them full information about all sorts of different treatment options. Early recognition of VVA, GSM, proper counseling, and personalized strategies are the key step in improving the quality of life of postmenopausal women. As with many clinical, just a minute. Spectrum of GSM requires the clinician to consider the effect on the patient's quality of life. This is the most important, how they're feeling, whether they're improving. That is the most important thing we need to say. Although situational lubricants and regular moisturizer effectively pacify many symptoms, but definitely local estrogen is safe, effective, and affordable way to treat the vulvovaginal changes of the menopause. With this, I'd like to thanks everyone. Thank you very much for kind attention for my lecture. Thank you very much.
Thank you so much, ma'am, for such a brilliant lecture. So many new things we have came to know today. Ma'am, regarding this DHEA vaginal, as you suggested, ma'am, have you used that in your patients?
Well, actually, in Bangladesh, I am sorry to say, Prastron is very expensive too. It is not available here. But
Okay.
my friends in Singapore, they're using that, and their patients are doing very well. They are answering that they are improving a lot.
Okay. Because as per my knowledge in India also we are not having such kind of preparation of 6.5 mg. But that's a very good, till now we are getting daily, we are getting new updates on this. So that's a very good information. Thank you so much, madam.
Most
Madam,
welcome.
with your permission, can I take some questions we have received
Sure.
with you? Yeah.
Sure.
Okay. Friends, meanwhile, those who have joined here, if you are having any questions, please you can write here. Ma'am, there is one question from Dr. Patil. He's joined all the way from Satara, Maharashtra. His question is, does untreated Candida vaginitis also causes the atrophy?
Well, that's a very good question. If a long-standing candidas, untreated candidas, there's a change, inflammatory changes, and all we know that inflammatory changes causes fibrosis, and there's chronic inflammation. It causes thickness and dryness. Yes, the answer is yes. So we have to treat the candidiasis too. On top of that, she is actually menopausal.
Yes. Thank you, ma'am. Thank you, ma'am. There is another question from Dr. Sena from Delhi. The question is, Madam, please enlighten us. Can vaginal atrophy affect the bowel movements?
Well, that is a very tricky question. Actually, we don't have a direct relationship between the vaginal atrophy and bowel movement. That is a two separate organ. But definitely, I don't know for whom you actually talking about. If it is a menopausal woman, we all know that there's a sluggish of bowel, movement. The peristalsis is decreased. They are not walking too much. They are sedentary habit, and they don't eat too much fibers. Absorption is less, so the constipation is very obvious in those women. But if you talk about the younger women, no, there's no relationship.
Okay. Thank you, ma'am. Ma'am, there is another question from Dr. Joshi. Madam, please enlighten us about the treatment of urethral atrophy.
Yeah, that is a very good question, Dr. Joshi. I have already told that during menopause, estrogen deficiency also causes urethral atrophy. I have shown the picture,
Yes.
huh? Because abundant estrogen receptors are in urethra, trigone, and the vestibule. So as a withdrawal of that, urethral submucous tissue, the urethral blood vessels plexus, they all atrophy. So there is a loosen and also laxing of the urethra. So women suffer from the laxity of the urethra, that there's sometimes incontinence and recurrent UTI. That all happens because of less blood supply and the thinning of the urethral lining.
Yeah.
So if we give the estrogen therapy, definitely we have to keep in our mind, it's not only the vagina, we have to touch the urethra as well, so that the urethra, the estrogen can go to there and they can work in the receptor.
Yes. Thank you, ma'am. Ma'am, we had received some questions here also. Can you unmute them so that participants can ask their questions? Yeah.
Yes, ma'am.
Yeah. So, Dr. Chinwe, if you want, you can communicate here with us. Dr. Chinwe is joined from the Africa. He usually joins my shows. Yeah. Madam, his question is, so there is no need for periodic endometrial biopsy while using the estrogen cream. What's your opinion?
Well, thank you, Dr. Chidwi. You're far from Africa. Thank you so much. Yes, your question is very intelligent. I have already mentioned, if somebody is on local estrogen therapy, the absorption is very minimum, and that doesn't cause endometrial hyperplasia because the serum estrogen remains very low, like postmenopausal. So you don't need to go for the biopsy. But yes, you are very right. If somebody is using systemic estrogen therapy, and if there's something, bleeding, then probably there's option for endometrial biopsy. Thank you very much.
Thank you, madam. Ma'am, another question is from Dr. Sushma Khan. Dr. Sushma, from where you have joined? And anyhow, thank you for joining. Her question, there are the patients with the recurrent vaginal infection, vaginal itching and burning towards menopause. What can we do for this? I think madam has very beautifully covered in her slides. Anyhow,
Hey, Dr. Shushma, this is a very important question. Daily we are getting this patient.
Yeah.
So, Shushma, if you have heard my lecture, I told that you have to take the history. Sometimes we're very much biased with the menopause. It could not be the only menopause. There could be some infection, diabetes, hypothyroid. So we have to look at all those things too. And of course, if there's no obvious reason, and it is obvious that it's because of the estrogen deficiency, definitely local estrogen will help a lot, even recurrent UTI. Thank you very much.
Thank you, madam. Thank you so much. I think with this, we have no more questions. Any more questions, Dr. Suman?
No, madam.
No. Yeah. Yeah.
Hello.
Yeah. Hi, Dr. Sunita. Yeah.
Hi. So I just wanted to ask, ma'am, there are patients day and night we are getting after menopause, say about 5 years or 10 years menopause. They come to us with the continuous itching. I mean, you give them something, lubricant, estrogen creams, and all kinds of gel, but then they'll again come back because the itching is so intense, they can't sleep in the night, and it is really, really disturbing. We know that it is vaginal atrophy, but what can be done? How we can help these women?
Yeah, Dr. Sunita, thank you for your wonderful question. But I am just wondering, itching, you have mentioned that itching. Does she have any diabetes?
Itching, especially inner of thighs, maybe groins, I can say, and out on the labia.
Right. Just because of menopause, intense itching is very unlikely. There would be some itching, but intense itching, what you're telling, that groin, the outer side of the vulva, probably, is she suffering from any skin disease? I don't know. So we have to also look at that. But if you don't find any skin disease, any candidiasis, then only atrophy doesn't do that much itching. So we have to look for the lichen planus, lichen sclerosis, psoriasis.
Okay.
Thank you very much.
Yeah, lichen sclerosis, right. Thank you.
Welcome, most welcome.
So I think with this, we have finished the questions. So thank you, madam. Thank you once again for enlightening all of us with your immense knowledge. I know madam schedule is very, very busy, and even though madam has taken out some time for this series, ma'am, before we wind up, there is one more question from Dr. Sushma Khan. She's writing, for overactive bladder, what treatment you will advise?
Well, that is a huge chapter for overactive bladder. Really, it's like, like ocean. Why she's having overactive bladder? What is happening with her? Is it anxiety neurosis? Is she suffering from any stress? Is she having some disease, interstitial disease? A lot of things we have to ask the patient. We have to exclude by the cystometry. Is it really overactive bladder or something else? Estrogen hormone has not much to do with overactive bladder. We have to go for all the drugs like Uromax, all these drug blockers. Those drugs are important rather than estrogen alone. But yes, if it is, anxiety, tension, if he's suffering from no other pathogenesis, probably we can help with some estrogen therapy. But in reality, estrogen and all the evidence, estrogen doesn't have any effective role for the overactive bladder. Thank you very much.
Thank you, madam. We have received a lot of appreciations for your talk, as always.
Oh, I'm honored. Thank you, Ritu. Actually, it's wonderful. And thank you so much to invite me. And I felt honored to be the part of this marathon today. And my heartiest thanks to all of you, and also invitation for you all. Whenever you are coming to Bangladesh, please contact me. Me and my husband is alone in the big home because my children has gone. So you can come and stay with me. Thank you very much.
Sure, ma'am. Sure. Thank you. Thank you so much, ma'am. Yes,
Okay.
some doctors are asking, and the recording of the YouTube here, the program has gone live on my channel. You can search with my name, Dr. Ritu Sanpani. Anyhow, I will post the YouTube link of this on all the social media. So thank you to all of the doctors who have joined, dear friends, all across the geography. So, and thank you once again, madam. Thank you, Shield Pharma, for giving us the platform. So with this, we will wind off of the session of the today. I am able to see the Dr. Shikha Singh. Yeah, thank you, madam, for joining. Dr. Leela Mohammed from the Saudi Arabia. Thank you for joining. Dr. Alka Kuthe, madam, and so many other friends have joined. Yeah, hi, Kusum, madam. Kusum Lata Meena, madam. Thank you for joining. So, so many friends have joined. So with this, we will wind off for the session of the today. So friends, please stay tuned. See, we will meet again on next Thursday at 8:30 p.m. Indian Standard Time with some another interesting topic. This series will continue, though now we have started a lot of physical meetings, but this series has been appreciated by all. So every week on every Thursday at 8:30 p.m. we will meet again with some one more icon, and we'll discuss some interesting topic. Thank you once again.
Thank you. Bye-bye. Good night.
Good night.
Bye.
Thank you.
Bye.
Thank you,
Thank
ma'am.
you, Shumon. Thank you. Bye-bye.
Thank you.